and a special welcome to our speaker today, Dr. Neela Patel. She is associate, among many things, right? She's associate professor and chief of the Division of Geriatrics and Palliative Care in the Department of Family and Community Medicine at the UT Health Science Center San Antonio, or UTESCA as we call it. Dr. Patel developed a model of integrated care for older adults across all clinical settings called the CARINO approach. And I just find that name so fantastic. And she's gonna be talking today about the one extension, which is CARINO en su casa. And when I made this program, I say, I wanna have that in the Valley. I want more, and I need more CARINO in our homes, in nuestras casas. So this approach is linked to community, is based on linking the client, the older adult, and their family with community resources. Also, she has been and still is, of course, instrumental in the Glenn Biggs Institute team that serve communities across South Texas. We always mention the education of the person, not only to recognize the roots, but also to portray to the students that you can come to be whoever you want, coming from very different perspectives. She graduated her bachelor's degree in chemistry and botany and zoology in Bangalore University in India, where she also finished her MD of predoctoral program, medicine and surgery. And then she moved to Colorado, University of Northern Colorado, where she finished her MPH of community health education. So we can see how her heart was already towards the community. And later on, she finished her geriatric medicine and postdoctoral studies at UTESCA. So she's been in contact with the needs of the community since very early on in her professional and academic life. So very welcome, Dr. Patel.
Thank you. Thank you so much for the introduction. I just wanted to say I have no financial disclosures in developing this model. We've got all the support from my department leadership and the UT Health San Antonio leadership. This is something very dear to President Henrich as well. The main objectives, I thought I'll describe, first define what the approach is, the CARINO approach, and described how we developed it. It wasn't something that just happened overnight. It was years and a lot of iteration in how we do things, a lot of reflection on what we do as a team, and getting us back to focus on our mission and vision and empowering people, especially older adults and families, to live better and have better health. Then defining the nosotros approach. So our department also has promotoras that work in the advanced primary care project. And so after having developed the CARINO approach, there was still something missing. We were only catering to the needs of the tip of the iceberg. We really needed to go into the homes and help the people where they are. And that's where we thought of combining and collaborating the nosotros approach with the CARINO approach. And that is what we developed as the CARINO en su casa. And we're going to, so as I said, all of us are following some part of this approach, or all of this approach, maybe in a different way. But at the end of it, I want to keep a lot of open discussion, because this is not just for primary care. This approach is encompassive of everybody who ever touches an older adult, whether it's a social work, whether it's a consultant, whether it's a hospital, or post-acute or long-term care, whoever is touching the patient and doing something to take care of them for better health. Where we are at, we can implement things so that we can communicate better and keep really the patient and family as the heart of everything we do, and making their lives better. And ours too, because then it makes what we do more meaningful as well. So the CARINO, so as we used to call this model as the UT Senior Health Care Model, because our clinic was called as the UT Senior Health Clinic. And then I said, you know, the UT Senior Health Model sounds too technical and really doesn't describe what we actually do. So I asked one of my colleagues, who's now the medical director of this practice, Dr. Davila, I said, hey, tell me something in Spanish. What would you say for what we do? She said, you mean something like CARINO? I said, yeah, exactly like CARINO. Now you tell me, now you tell us how do we, in the mnemonic of CARINO, describe what we are doing. And so we all then sat together and brought what CARINO really stands for, what we do. It's really fondness. We're very tenderness, love. We just, what's in our heart is what we give, right? So the C we thought was compassionate care. We want care for our patients to be the care that we would want for our own family members and for ourselves, okay? And basically our patients, especially older adults, they go across different settings. They may come to the clinic, we see them in their home, they may end up going to the hospital, they may be in rehab, and then they may end up needing home health services, and finally may need hospice services as well. So basically it is care across all the settings. You want the same kind of care, the same level of care. And advocating for patients and families with everybody who's touching the patient, whether it's a consultant, whether it's a social worker, whoever is helping in caring for these patients, we are keeping the focus of what the patient needs. Oh, insurance is not going to cover that. No, we don't want to hear that. We want to find a way to get what the person and family need with all the limitations and challenges that we are facing. So advocating, you know, keeping on reminding people, hey, I'm sure if you want to find an answer, you will. So go ahead and do it. If this was your mom or your dad or your grandma, what were you going to do? How would you find the answer? That's how we need to do it. Then respecting for what matters most to older adults. Because sometimes we recommend everything, we recommend treatments, we recommend different options, but truly in shared decision making, we should be okay with accepting whatever the patient wants to do, you know, and so respecting what really is most important to them. Then intentional redesigning of processes and activities to meet the needs of our older adults. Okay, so sometimes we have like processes in place that are general, and really we know each and every person is different, especially older adults. And so you really want to change how we do things for them by looking at processes intentionally on a regular basis, having meetings, getting feedback, doing huddles, just to make sure that we have processes in place that are intentional to make their needs known and to meet their needs. Then nurturing, having nurtured relationships with families, with social service agencies and community partners. You know, it all started with building relationships with all of them. It didn't happen overnight. You have one interaction, it's a good one, and then you keep that contact and you develop it, and then you're texting or calling and saying, hey, I need help with this, or they call and say, I have a patient that, you know, really needs a good primary care or needs some palliative care support or whatever. So nurturing those relationships, you know, not just relationships don't just happen, and it's all about respect and trust, and it's only when you take time to develop it that happens. And older adults are wise. We don't have to make all the decisions for them. They really know what they want, and listen to what they have to say, you know. So that is CARINO, and that's the approach we developed. So this is a conceptual diagram. So the heart of where the approach started was the clinic. And then it's the inpatient and emergency rooms, our rehab centers, the home health and hospice agencies, the Alzheimer's Association, Area Agency for Aging, BIGS, all that we've included in this. Then the senior centers and the DME and transport agencies, whatever resources, community that they patients need. And then finally, it's the specialists or the consultants who also interact with the patients. They interact with one another. They also all report back to the heart or to the patients as well. So how did we develop this approach. I will discuss our journey. I just want to say, if anybody has any questions, feel free to interrupt in between. I have no problems answering questions on the way, if you want them to be answered right away, or we can wait till the end. So our journey began in our clinic. We were getting in the process of transformation to where we were all focusing on patient-centered care and keeping the patient as the focus and the person as the center of everything that we do. So all our activity of what to do for our patients and how to do it right, how to do it the way we would want it for our own family, started in the clinic. Okay. So in the clinic, we started developing a common mission and vision. We focused on process improvements. We took time for reflection and course adjustment, made people in the team accountable, ensured that we have a safe work environment. We optimized the electronic health record, because all of us know electronic health records can be a boon or a bane, okay, depending on the day and depending on what we need to do. And then building a neighborhood, because it wasn't enough for the patient to just have a patient-centered medical home as an outpatient clinic, but also to have like the consultants they go to, the community resources they use, the rehabs they go to, is the patient-centered neighborhood. And that should be something that we needed to focus on. And that was basically what we developed as the CARINO. So for building a common mission and vision, we just started with, we started having regular meetings every week at 7 a.m. for about an hour, because if we did it later, one or two people were missing because they had to answer phones or get patients in. So we wanted everybody to be a part of it, and we wanted to listen to everybody. So we started off with, why are we here? Why are we all practicing in this practice? Why are we practicing in this clinic? And would we bring our family here? And we asked, if we would bring our family, why would we bring our family? And if we would not, why we would not bring our family here? And so with the why are we here, it was so unanimous. And I wasn't even expecting it when I started this in 2012. When I asked, why are we here? It was common. Everybody was here for the patients and to help patients. And they liked working with older adults. And why we had a whole list of all the strengths of our practice and why we would bring our family here. And we had a whole list of why we wouldn't bring our family here. And then we prioritized and focused on why we wouldn't bring our family to our practice. We prioritized which issue we need to tackle and change. And that's how we kept the process improvement going every week. So we, in the priority that we made, we took issue by issue of concern or problem, and we asked what needs to change, okay? And what we need to keep because it's working well, okay? What we need to change, tweak a whole lot, and what we need to stop, you know? What do we need to stop? Is there something that we're not doing that we need to be doing? So we use like the color lights. The white light is basically continue doing, this is a good thing. Red light, stop it. The green light, it's good. And the white light was for something new, okay? Something flashing, something new, white. Green is you're doing good, keep going, okay? And then the yellow is, it's a good process, but it's really not where we want it to be. And so we need to change it, and then we would do our fishbone and our process quality improvement charts, and find out what we really want to do to make changes happen. And then maybe give it some time, like 3 or 4 weeks, and then go ahead and revisit and see, how's it working now? Do we still need to tweak it? Are we where we want the process to be? So all of our clinicians, our MDs and nurse practitioners, everyone has gone through the UT Systems Clinical Safety and Effectiveness course. And we also have had a lot of our staff attend this meeting. So based on which are the processes we wanted to change, they took it up as a project that they wanted to work on to make changes happen. I'm just going to show one example of what we did. So this is how we would be in our 7 a.m. meetings, and somebody gets up on the board and starts asking questions about, so here we are prioritizing about rooms and space and different issues over there. And then we draw the fishbone, okay, and find out what is the cause. And then we look at, okay, so which is the thing that we're going to focus on that is going to really help us make the change we want to make. So one of the projects that they did was, we had templates. And if you see here, we have like 3 patients scheduled at 9:30, 2 patients scheduled at 8:30. So we were overbooking in the same 30-minute slot. We were booking patients for the same clinician, MD or NP. And that was keeping the patients waiting for a long time, and that was affecting our patients' patient experience. And you tend to rush then when you're having 3 patients in the 30-minute slot, so you're basically giving only 10 minutes, or you're making the other person wait for a longer time. So looking at that, what our time wait time was before the intervention, and then after the intervention, how much time we reduced. By 8 minutes, the wait time reduced. We were almost close to 15 minutes, which is quite an acceptable time for the person to wait, because the staff need about 15 minutes to triage them and get their point of care testing and all that done. So then we changed it to where there is only 1 slot per half an hour and a full hour for the new patient slot. And then we locked the slots for same days so that they could not overbook, but then there were special time slots available. If patients walked in and needed to be seen the same day, then there was a way for us to see them. Okay. We also took time. So after we make all these changes, it wasn't all the time you meet, you decide on a change and then done. Then we would take time every day. We have a morning huddle, and we discuss how the workflow is going to be for our patients in the clinic, for our patients in the nursing homes, in post-acute, in the hospital, and our home visits, which are the patients we need to go for home visits to. And then also the population health management, a panel of patients with uncontrolled diabetes or dementia, where the caregivers are feeling they are having a whole lot of burden and they're needing help at home or respite care. So we discuss that every morning. We do have daily huddles. If there are staff missing, so the workflow preparation and adjustment is if there are staff who are out sick or clinicians who are out sick, or additional patients that need to be seen, but we don't have any open slots, then who else can come into the clinic and help with seeing the patients? And regular all hands. So suddenly, if people felt like we all needed to touch base again, we would make sure that we get to meet. So we do have a daily huddle every morning, and it's for 30 minutes. And now it is in Zoom because of COVID-19. And even though we've started face-to-face visits, like we have people with social distancing, there are few people in this conference room, and the rest of us sit in our offices and log on into Zoom so that we maintain the social distance. And then we also have a 7 a.m. meeting on the 2nd Thursday of every month, and the 4th Wednesday of every month. We have a lunch meeting from 12 to 1 to basically have the all hands, have all the team members, the MAs, the front desk, the schedulers, everybody in to give us input and tell us what is the feedback on how things are working or not working for us. So again, the monthly and the 7 a.m. and monthly meetings, mainly what we continue, stop, change, and start. And we also do a lot of team building. So we do the glad, mad, sad. What are you glad about? What are you mad about? What are you sad about? So that there's no frustration on a day-to-day, and it's a more joyful environment, and people are happy doing what they do. Accountability. So many times, people don't realize that how what we do is affecting the rest of my team. And so we asked everybody to write down what they thought was their role and responsibility, like MA, LVN. Even we asked our nurse practitioners and MDs to write down what they thought was their responsibility in patient care. And we defined what is each one's responsibility, who does what, because then there is accountability. If we say, oh, we're all working as a team and anybody can do it, then nobody takes the responsibility or owns it. So we have it like, if you touch it, you own it and you complete it. If you don't, or if you're not able to complete it after you've touched it, then you need to communicate and let the people who are in the practice know that, hey, I'm going out to the nursing home, but I touched that message. I'm not going to be able to take care of it. Can you take care of it? Okay. And how does, so we will reflect a lot on how what we do affects the team and how what we do affects our patients as well. We focus really hard on making our environment safe and respecting and trusting for diversity of opinions and team engagement, and really not allowing people to say things as they are, not being afraid of telling it as you see it. And if y'all come to one of our meetings, you'll really see how everybody speaks up. Nobody's afraid to say as it is in a very respectful way without like pointing fingers. We constantly keep saying it's not about an individual, it's about a process in place for us, for our patients. Okay. So for a safe environment, we use what we call as the adaptive reserve model. We do have surveys, anonymous, that are sent out to our team. And basically it's focusing on relationship in the practice and how it works, mindfulness, being open to new ideas, respectful interaction, being honest, tactful, mutually valuing and exchange and interchange of ideas, heedful interrelating, channel effectiveness. So basically using a mix of face-to-face interactions versus sending emails or text messages, and mix of social and task relatedness, diversity in like allowing everybody to speak up. So if people don't volunteer and say things, then we ask each one, okay, so Adalia, what do you think? Julia, what do you think? You know, and we tell them, please don't say same or you agree with others. We want you come with your idea and don't hesitate to say what it is. And trust, so that when we spend time outside of just talking about work and in team building and all that, we do develop a relationship. So this is our work family. We spend a lot more time here than we do in our own homes and with our own families in the week. And so this is our work family, and we do miss it. Like when COVID-19 and we were having to work from home, people were feeling really very lost, and they were missing work family. Yeah. So this is how the more outside it is, it shows that the environment is more safe and joyful, and the more internal it is, it means it's a very restrictive environment. Okay. So we also optimized our electronic health records, and I'm not going to go too much into the details of that. So basically, having done all these steps, we started relating with the consultants, with the home health agencies, with the DME companies, with the day centers and senior centers, the Alzheimer's Association, adult protective services, to make sure our patients are safer, the local hospitals, transportation, and senior networking and resources and groups. That is what we called as the CARINO approach. Okay. So as I said, we started with the clinic, and I just described to you all the processes we did in the clinic. But our patients just don't stay in clinic. They also go to the emergency room and hospital. So we started building a relationship with the hospital that our patients go most to. Our clinic is housed next to a hospital. And so we started with that emergency room, and we had an acute care of elders unit that we were admitting our patients to in that hospital. But as we started getting more patient-centered and our practice became more patient-driven, our hospitalizations decreased. Our patients were not being admitted to the hospital so much. So we then converted our service into a consult service. So we went for meetings to the emergency department meetings. We went for meetings of the hospitalists to let them know of our practice and to also say, how can we work together? How can you let us know when our patients are admitted? And how can we help you, letting you know more about the person you're treating in the hospital or in the emergency, in the emergency room. And now we have care managers who basically interact, but we as consultants in the hospital are informing our patients, PCPs, about their hospital stay and what needs to follow up with it. After the hospital, we also go to a lot of post-acute and nursing home and acute rehab places, and many of them after a hospitalization went to those. So we basically chose a few where we could have our patients go to, so there was continuity of care, there was relationship building, we were engaged in their care and in what their care plan was for their rehab and their stay in post-acute care. So we started developing relationship with them, and then we got them to interact with the hospital and the emergency room, so it was more communication, and everybody were on the same page. Many patients, our older adults, do need home health, and towards the end of life, they also need hospices. And so we, there are tons of home health and hospices. So we decided, based on the feedback that patients gave us, which was a good home health agency, like the skilled nursing and PT or therapy was really good, and the same with the hospices, we narrowed down a few that we would relate to, and we gave our cell numbers to them. We had their leaders and their nurses' cell numbers so that they were more easily accessible, and they would call us when they are in the patient's home, or not hesitate to do what needed to be done for the patient. So we narrowed it down to a few home health and hospice agencies. Because many of our referrals came to us from the Alzheimer's Association and also the Area Agency for Aging. But we also found that as an excellent resource for our patients and caregivers, especially for persons with dementia. And then, of course, when the Biggs Institute formed, that has been a big support for our patients. So it's been mutual. They have primary care for patients who don't have primary care, and we do have a center to send them to for additional resources. Okay. We have a lot of senior centers in San Antonio that are free to seniors, and the three things really that helps a person age well: exercising, in socializing, meaningful socialization, not just with family, but with peers, and a purpose in life. And so we send them to a lot of the senior centers. And the senior centers also send us patients, their clients who don't have health care or who need health care. They reach out to us and help us to get to them. A lot of our patients need DME. A lot of our patients need support with transport to and from healthcare offices. And so we collaborate and partner with them and share the resources with our patients and families. And finally, it's the consultants, cardiologists, neurologists, nephrologists, whoever the patient goes to. We made it a point to see that we interacted with them and kept an open door for them to interact with us and shared the resources. So we have many times cardiologists who will call us or text us and say, hey, I'm seeing so-and-so and she needs this, where do I refer, or who should I send them to? And so, everybody then is not working as a silo, but working together, holding hands with the patient in the center. So this is the approach we developed, and it is now a norm. It's become a natural process. We don't know any other way now of how to care for the patient. In the practice, every staff member knows, they went and saw cardiology last week, so if the note is not visible in our EMR, they'll go ahead and get the, if a patient is hospitalized, they will make sure they get the discharge summary and hospital records. The patients are called within 24 to 48 hours of discharge so that there is a safer transition. But despite doing this, we only reached the tip of the iceberg. Okay, there are more than 90% of older adults in San Antonio that needed our services and were not available we were not taking care of them because we were in our practice, in our clinic, and in our nursing homes or the hospital, but we were not going to them. Many of them didn't have a way to come to us. That is what brought to us, what can we do beyond the walls of our office? Okay, there's poverty, inequality, segregation, language and cultural barriers. We have only a couple of our clinicians who are bilingual. We have people from different, I speak many other Indian languages. There's a doctor from Nigeria, and she speaks a couple of dialects in Nigerian, but nobody who really could cater to the South Texas that we really wanted to help care for. Then the inability of the population to navigate the healthcare and reimbursement systems. Like the other day, I went for a home visit with a promotor, and I spent about 45 minutes talking to the patient, and I went there thinking he's uninsured, has no insurance, he had no permanent address, and every week he would be in a different place. His main problem was he didn't have a CPAP, and he wanted me to help him get that CPAP back because there was a fire in his house and his CPAP was burned down, the wiring and all that. So I said, okay, I will. There's Project Men here in San Antonio. Let me see how we can get them to help us help you get a CPAP. And after 45 minutes or so, he then digs into his pocket. He pulls out this wallet, which has a bunch of cards, and he slowly then pulls out his cards. It just turned 65. He does have insurance, but he didn't know that he has insurance, that he had Medicare to help him to do all of this. There's also lack of transportation and ability to visit specialty care providers. So if you all have seen the medical center here in San Antonio, most of our specialists are in the Medical Arts and Research Center. There are buses which do come here, but many of our older adults with walkers or wheelchairs, it's a little bit hard. And if they have dementia, it's even more hard. To find their way, they get confused with the bus, and many who don't have dementia also, it becomes sometimes they have to change to buses to come here from the south side. So that is where I felt we were reaching only the tip of the iceberg, and we really needed to go there to them. Also, they have multiple comorbidities. They require a lot of consultations, and everything just could not be from an office situation. And also not having trust in the healthcare system with previous experiences, either their own or their family member, was one of the biggest barriers for them coming for healthcare. And that's where we decided, okay, we really need to go to them. We need to care for them in their own homes. And so we wrote a grant to an organization here in San Antonio to help support our service of CARINO and Casa to go to the patient's home. So this is basically the same what we're doing in our clinic is in-home comprehensive coordinated care. But here we are collaborating with promotoras, either promotors or promotoras to help us with knowing the families and navigating with them. Because even though we want to go into their homes, many of them really don't want us to go into their home. But we've started collaborating with an agency that works in the west side of town called the House of Neighborly Service. And many of these patients go to the House of Neighborly Service for breakfast and dinner, lunch and socializing and doing meaningful activities there. Of course, all that stopped because of the COVID-19 situation, but this community center was still available for us as a neutral place to see the patients there. And we saw only 3 patients at a time, and basically we had them all come at an hour apart, and there was only one person with a promotor or a promotora that we are seeing in the center, and trying to find out what their needs are, which are beyond medical needs. They're more like social needs or psychological, emotional needs sometimes. Sometimes there's social conflict that we need to help resolve with them. So we are basically now doing the visits either in the house of neighboring service or going along with the promoter or promotora who already has a relationship with the person and family and is helping the patient and family develop a relationship with us. So the little bit about the Nosotros approach, it is basically the heart-driven approach, and I think many of you all are already familiar with that. We need to be trusting of the patients and families' homes that we are going to, and they need to be able, and we need to behave in a way where they can trust us. Okay, our actions speak louder than what we say. So we need to behave in a respectful way where we can earn their trust, and we need to be going with trusting them, not with an attitude of, oh, you know, whatever we're going to do, it's never going to be enough. They're not going to change. They're not going to change their behavior. They're not going to take the medicine, or they're not going to. No, we cannot go that way. We've got to trust. Our intent is to help. Our intent is they want the help. And we need to behave in a way where they trust our intent and know that we are out there to help them help themselves and to empower them. So currently, we identified a few patients from our practice who came from there and have a difficulty in coming here, mainly those who missed multiple follow-up appointments or were recently seen in the emergency department or recently released from hospital care. But we also got a list of patients and persons who need to be seen from the House of Neighborly Service. Many of them do not have insurance and some of them do, but that is not the criteria. For us, only the criteria are patients who really need us, no resources, and with the criteria that I just described. Okay, so there are certain zip codes that we go to for this service. Right now, currently, we're doing it 1/2 a day a week. As the community develops more trust in us, we will, and the need increases, we will increase the number of times we go there. This project was started in January of this year, and so far we have seen only 15 patients because we started seeing them, and then when COVID started and we were told to socially distance and telehealth and telemedicine took over, we got the directive from UT leadership not to do home visits because for our safety and our patients' safety, they didn't want us to do it. But now we just restarted again in the last couple of weeks. So we are hoping that it will pick up, and currently, the House of Neighborly Service has about 40 patients who are uninsured, and we are thinking those are the ones that we want to see first, in addition to anybody from our practice who we see, who we think needs to be seen. Basically, this is the CARINO approach and the CARINO in su casa. I've kept a lot of time for questions. I thought I have like 50 slides I'm going to go over, and maybe I spoke too fast. But I think it should be more of a discussion for us to see how we can implement this in whatever practice each one is in. So there are differences like between the patient-centered medical home and the CARINO approach, because many of them may think that this is just PCMH and primary care, but there are really a lot of differences. The PCMH is general to all patients, all ages. The CARINO approach, what we've developed, is specific to frail older adults. The PCMH is more office-based and ambulatory setting. The CARINO approach is beyond office walls. It's virtual teams. It is collaborating with each and every team member who interacts with the patient, and it is all integrated together. Population health in PCMH is very disease-specific, diabetes control, cancer patients, etc. Whereas here in CARINO, you're looking at the whole person and what they need. And many times it may not just be disease-specific needs or health needs. It may be more social health needs, or mental health needs. again, the care coordination is from the office, and you have a care manager from the office who calls to check on the hospitalization, their discharge. Now in the CARINO, we do go to the homes. We either send them promothoras or home health or hospice agencies based on what the patient needs to actually make a visit in the home and see, reconcile the medications, make sure they've got the DME they need, and there's a clear follow-up of what was done. We started our home visits even before we did the CARINO and Casa. Three of us, a nurse practitioner and two of us physicians from our practice, started doing home visits for all the patients who were discharged from the hospital, especially the frail ones and who had difficulty in getting appointments to come here. The quality measures are pretty much the same for the PCMH and the CARINO. Everybody looks at disease-specific quality measures, also the utilization, like reduced hospitalizations, ER visits. But I think the biggest difference is the relationship building and the collaborative working with all the partners. In the CARINO approach, we have given a big hand to caregivers and our family members. We formed a patient and family advisory council, and they meet once a month, and they constantly give us feedback of what's working, what's not working, and what we need to change or tweak. They are a voice of the community and keep us on track to stay focused on doing what's right for the person and family. Okay. So without realizing it, the approach that we use to keep the patient and family as the focus really is the 4Ms framework for caring for older adults, focusing on what matters most to them. Medication, the pharmacist is a big part of our team, and we do have our pharmacist who does chart checks, who also sees patients in person and has been doing telehealth visits in this emergency situation. We look at the mentation. We know many times dementia is also an iceberg disease. We see only the tip of it. Many of them have it, are living in the communities, and so is depression. So we try to focus on early screening of dementia and depression, and then mobility, not taking away from patients what they can do, and making sure that they are independent as long as they can be, focusing on their functional independence. So basically, our CARINO approach can be an adaptable, age-friendly health system with any practice. It doesn't have to be, it's not in a physical space. It's a virtual space and collaboration that we all build together. Okay. There's no one size fits all. We all have to realize where we are at with our practice, what are our goals, what's our mission and vision, and then focus on one thing at a time. So I can say that in the last 3 years, it seems like we are in autopilot and the practice is running smoothly, but we had started off in 2012. So it took us almost 5 years to get to where we are. And now it's been like 8 years since we've been running the practice this way. It's more an approach, and it's not like a practice of the people. It's an approach that the team follows. So it's a culture that we've created. And when we are hiring people, whether it is clinicians or it is staff, we tell them what we do. And if this is what they want to do, they become a part of the team. If not, we've had people who say this is too much for them to handle. They feel overwhelmed that we are taking care of patients beyond and above being in the clinic. So now I'll open it out to questions.
Thank you very much, Neela. Wow, this has been it's amazing what you're doing, and you are so generous sharing with us how you did it. And you are totally right that we want to learn because we want to bring CARINO in su casa and the CARINO approach to the valley. So thank you so much. With this, I'm gonna open for questions, comments, anything for our speaker, please.
Can I start, if you don't mind?
Please.
Hi, thank you very much. That's a wonderful program. It really shows how much care and dedication and truly caring about the patient you guys have gone through, to create this program. So that's wonderful. So, I mean, you mentioned one of the results, like that you had early on was that you decreased the frequency of hospitalization, which is great. So do you have, I mean, is it part of the program to collect outcome data and what happened? It's,
Yes, we do. So basically, we started this with our practice, and now UT Health liked what we did and liked the outcomes. Our hospitalizations were less, our ER visits were less. So our utilization of healthcare services of the population, even though it's very frail, was very less. So they made that as the UT Health way for our accountable care organization. And what all processes we do here. So now they have the huddle, they look at what's working, what's not working, what needs to tweak and all that. So I did not share our hospitalization rates and all that here, but we had a contract with the hospital for the inpatient service that was giving us $500,000 a year. We lost that contract because our hospitalizations decreased.
because it decreased.
Yes, because they said we were not getting them enough patients. But I said, you know what? We are doing what's right for the patients.
Exactly.
If the money doesn't come from the hospital, it's going to come from somewhere else. So every time when I was medical director, now I have Dr. Davila being it, and I would go for these meetings.
Yeah.
I would tell, don't worry about the numbers and about the money. Just do the right thing for the patient, and the money will come. And we are a sustainable practice. Even in this COVID-19, they actually announced it in the MSRDP that ours was the only practice that still was not in the red, because we were just there for our patients in telephone and telehealth visits, and none of those visits were reimbursed. But our practice was sustaining because we are just focusing on what the patients need.
Well, that's one.
I don't discount that we need to focus on the money too, but I think that should not be what drives the care we provide. It has to be the CARINO and the nosotros that drives the care we provide.
Absolutely. You know, related to that, did you have any measure for well-being for the people you are treating? I mean, that's probably they were feeling much better.
So the adaptive reserve, now that is also something that UT is doing across for all the practices. Every quarter they send out a monkey survey monkey to us. For all of us to fill in, and they have shown that the culture of UT Health has changed, and the environment is much safer for people to talk and share their ideas without feeling discriminated, or without feeling afraid of talking, like saying like, I'm only a medical assistant, I cannot say this, but they do speak up. So we feel good, like in UT itself, there has been dissemination of what we do here. So it's time now to disseminate beyond UT Health San Antonio.
Absolutely. Congratulations.
Thank you.
And we have one question in the chat coming from Dr. Cynthia Cavazos Gonzalez, and she is the director of the psychology clinic. Mm-hmm. So I guess she's curious about, she says, how much training with staff and providers did you do to implement the approach? Also, how to manage patient adherence to treatment with Latinx community?
So as I said, no one size fits all. Let me handle the first question about training. So training, like every day in the daily huddle, we would pick up one thing that we wanted to reinforce on. And once initially, when we started in 2012, we were meeting every week, 7 to 8 a.m. meeting, and every Wednesday afternoon, 12:30 to 1:30, we were meeting. But as and how things started falling in place, and there were not so many processes to change and tweak, we decreased the frequency to twice a month, 7 a.m. meetings, and twice a month, 12 to 1 p.m. meetings. But then now we've reduced it to once a month, 7 a.m. meeting, but every Wednesday, 12 to 1 p.m. meetings. And the staff, the environment is such that if something is bothering them or a process is not working and that's making people frustrated, they can call in an ad hoc meeting anytime. So that is the one thing of how to train the staff. The second question was about how to focus on patient compliance, right? So basically each person is different, and we saw who they related to. So it wasn't only the NPs or the MDs who were working on it. We do have a PharmD in our practice, whether the PharmD is going to help. we collaborated with some home health agencies. So as I said, we have medical director contracts with home health agencies, and we do the same kind of training for the home health agencies too. Look at the person, what they need, don't judge them, and your behavior should be such that they trust you. You're going into their homes, you know, you have to win over and earn their trust. So we do that training, and we see who they trust and relate to. Then we have that person help them move from one to the other. And then we have a combination of face-to-face visits. Maybe the home health goes or the PharmD sees them, and then we ourselves as primary care will call and find out. Hey, and then respectful. So if they say that, you know, I'm not going to take that medicine because it causes my blood pressure to do that, we don't say, okay, if you don't want to do this, then there's nothing I can do to help. What we say then, okay, what are you willing to try? These are your options. Are you willing to eat less bread or less tortillas, or, you know, are you willing to eat a little bit more of beets? Are you willing to reduce your portion sizes? Then, you know, they realize that I'm not saying this for me, I'm saying this for them. Or we, you know, and so then they say, okay, I know, Doctora, that you really are trying to help me here, and I'm being stubborn. But we take the time, we don't try to push them. We are respecting the decisions they're making. So it's true shared decision making that comes here. As I said, it doesn't happen overnight. It doesn't mean all the patients, all the 3,000 odd patients in our practice are perfectly well controlled and in good health. No, but they're at least on the track to that. And we have been able to reduce them, the medicines they take, the number of consultants they see, the number of hospitalizations they have, number of tests we order, the MRIs or blood work. For our patients, we're doing like maybe once a year, and if they're diabetic or something, twice a year. They don't have to come in for blood work every 3 months. So it's each person, each of us clinicians are different, but we all know what the goal is, and each one does it their way with how they relate to patients. So we've also had patients who've changed their primary care within our own practice because they relate to one another better. So some of my patients sometimes don't like the directness of me telling them, you know, these are your choices and you do. They want to be told what to do. So they will go to another clinician in my practice who'll tell them what to do and not give them a choice. So it's all about the person and seeing, okay, what can I do? What I'm doing is not working. What else I can do, or who is the person or the team member who's going to help them?
So I think that what you are telling us are ways in which we can grow to bring CARINO approach here and CARINO en su casa here. And we definitely want, you know, to pursue that route. But I really want to invite the people from the community and the public agencies that are here in the conversation. You know, I'm wondering if they have any question, comments. Is this something that you see that we need in the Valley, that we might be able to put this together with the support of Dr. Patel?
So this is Gustavo Salinas with Adult Protective Services. And from my experience and the work that we do at the agency, we find that there is a need for the same reasons that you were talking about. Transportation, you know, just navigating through the system. How do you apply for Medicare? How do you apply for VA benefits? How do you access access care or low cost care, and language issues? So definitely, I think that it's something that if we could emulate something like that here, it would be of great benefit to the community, because a lot of those barriers are the same.
So one of the ways we started here is in San Antonio. They have a B2B meeting of all the agencies, the community agencies that work for older adults. So many of the, like the area agency for aging also hosts it. And many of these nursing homes or post-acute facilities or acute rehabs host it. They call it as the B2B meetings. It's one Friday a month and every third Wednesday of the month. So I went to one of these meetings to try to find resources for our patients, because we didn't know more outside of UT where to get resources for our patients. We knew about APS for patients who really we were very concerned about, and I even have a couple of APS officers who will take my call and tell me what to do. So, but that was only what we had. So then we started going for these meetings and learning about resources for them. Project Mend is where they provide at subsidized rate DME, or sometimes even give free DME for patients who don't have insurance and who need it. So that's how we got all these resources. And maybe that could be a starting point in the Valley, where you start organizing these meetings for everybody who's working for older adults, inviting them. And how it works is each agency hosts the meeting. So it's not a cost on any one person, and it's not too much. And everybody is allowed to bring their flyers and all that and put it out on the table. So the first 30 minutes, we just go around socializing, talking to one another, picking up flyers, finding out the resources. And then each person who comes there drops their card and is given like a 1-minute elevator talk to tell about their practice or to tell about their agency and what services they offer to older adults. So we had like home for seniors or estate planners who help people downsize and move into assisted living. So I got to know so much about the resources that I made it mandatory for everybody in my team to go and attend a B2B meeting 2 or 3 times in the year so that they get familiar with the resources. And then UT also conducts the silver, in May, they conduct this, it's like, I'm blanking on the name, it's something silver, where they have all, again, agencies doing clinical care, research, social resources for seniors, and seniors come. It's like a seniors camp, or, you know, all exhibits for them and resources for them. So they do come there, and that's another place where we got to know a lot more of the resources for our.
And I think we have here in the Valley started, Mr. Salinas has been an active partner of different initiatives that I think that brings together the agencies and community-based organizations. One is the Senior Coalition, but I think the area Agency on Aging, it's also, and his office and others are already talking. I think that having the goal, it's very important. Having the goal to say, okay, we're gonna bring CARINO. We're gonna bring CARINO in su casa and try to model what you have in San Antonio. Of course, adapting it to the local realities. We have one question from Dr. Miner, who is curious about the role of social workers or the Department of Social Work. How does this work?
I'm so glad. We do not have a social worker in our practice, but we partnered with Senior Path Associates in the community. And they, again, her number I don't forget. I can text her, I can call her. I call her right in front of the patient and family, and I connect them together. They go to the patient's homes, or they will come to our practice and help with the social needs of the patients based on whatever it is. And they were another who helped us identify a lot of resources for our patients. They also help like veterans who need veteran support, or people who need respite care, or those who cannot afford a nursing home but cannot be taken care of at home. They've helped us find personal care homes. They've helped caregivers start their own personal care homes with 2 or 3 people. So we've used the community, the Senior Path Associates to help us with that. But now with the bigs, we do have social workers. So we are using the resources of the social workers from the bigs, and UT, the quality team with our ACO does have care managers. So we do have a care manager in our practice. But again, the care manager with UT and the ACO, all office-based. Whereas the Senior Path goes to the patient's house. We also use the social workers from the home health. So any patient that needs home health services and also has social needs, we will talk to the home health social worker and say, hey, Esther, so-and-so, this is the issue. Can you please work with the family and help and let us know what we need to do? We've even gone to the homes with the social worker, myself, and the home health nurse and the family there to resolve social issues that they have.
And one of our attendees asked, what happened when the person do not want to allow your services at their home or in the clinics, in the places that you work? Is there something else? What is the last resource you have to help?
So House of Neighborly Service is a community organization here that we've started collaborating with since January of this year. And they have a senior center place, and they have like a community room, which is where we're giving them the option if they don't want us to go to their house and they don't want to come to our clinic. But we also have the School of Nursing that we are collaborating with, and they have a mobile bus. So we are planning on taking the bus out. Again, we had decided that we were going to use it to go on COVID-19 restrictions, so we could not go with the bus, but we do have a mobile bus where we could see the patients there if they didn't want us in the homes. And the last is we were planning on writing a proposal with the libraries, public libraries and senior centers of San Antonio to see if they'll be willing to pilot, to see one of their rooms we could use for healthcare services or family meetings or whatever the patient, interdisciplinary team meetings with the patient and family to help them there.
And Dr. Patel, what about telecounseling? Is this how well received have been the teleconsultations?
So it's been a little hard, especially in the underserved population, because many of them don't have phones also. That's where we've really had to use the promoters, because they've gone to the house and made contact with the patients. And then after having made contact, they've scheduled them with us, and then patients have canceled and not come, and we've seen somebody else. So we've the half a day that we go, we've seen it, patients, but may not necessarily have been those that we had planned or set out to go and see. And that's only because the promoter has had problems with communicating with them or getting them on the phone. So telehealth really doesn't work a whole lot, but the other approach that we have to contact these patients who don't want to come to our clinic, who don't want us to go to their house or don't want to come to House of Neighborly Service, is using telehealth with the promoters. So we are getting an iPad and a hotspot, so that we can do the FaceTime visits with them, with the promoter in their house, because they will let the promoter go to the house. They may not want us to go to their house. So the promoter can help us to establish that relationship and develop the trust, and still for us to be able to give consultation and guidance as to what they can do and the choices they have that they could make to get better.
And what about, because of Dr. Shunsu has a question on participation of and the level of bilingualism of the care providers, but also I know because of her work, she works with people that are 90 or older. What about older adults? Because you may really, I mean, the oldest old, and she works even with centenarians in the Valley.
Okay, so our average age in our practice is 82. And for me, majority of my patients are older than 85. And like today, we've just seen 94, 99. I have about 20 patients who are more than 100 years old. So, and it's been both ways. Some of them are very with it, not taking any medications, maybe just one aspirin or something like that. And some of them do have some medical issues or maybe frailty in terms of functional ability being lost. But even if a person has dementia, we first talk to them only if they're fairly advanced dementia where communication is very limited, then we engage or totally relate to the family member or the primary caregiver. But we try to engage the patient in everything they want. And see, I do not speak Spanish. All I can say is no habla en español un poquito no mucho. That is all I can say, okay? But, and I do understand it. And then I will look with Uncle Google. I will type the English one and then try to speak in Spanish, and then I do the same. But despite that, patients relate. It's a relationship. And even if I give them the choice that I have NP Medina who will speak Spanish, or Dr. Davila who speaks Spanish, and you can start seeing her, they'll say, nope, they want only Dr. Patel. So I don't think that that way language is a barrier. You know, it's more the relationship building, it's more the trust, and it's more the caring that they are looking for, more than just being able to speak the same language. So it's basically the language of love and the language of care and trust is what they're looking for.
So if I could just interject, so it seems to me that I mean, I think it's a great program, and to make it viable in the Valley, I think we'd like to get all these folks that are doing the work together and sort of form like this like elder issues task force where you have a multidisciplinary team, you know. So I mean, I am willing to help with my connections in the aging arena. Like I don't have those connections necessarily with medical, but more on the social services. And so I mean, you can reach out to me, and I could help with organizing some of that stuff.
And truly, Mr. Salinas, that's one of the ways actually by when we focus on the social needs, because that is more important from a patient and person perspective, the social needs that they have. And when we focus on finding resources for their social needs, we develop that trust and relationship faster, rather than focusing on the diabetes and the dementia and the hypertension. If we focused on what their social needs are and provided that to them first, then when I say, you know, can we talk about your diabetes now, because it's really not where we want it to be, you know, and then they're more open to it. Because I did community medicine in India, and my practice was only in the villages. I got in a van in the morning at 6 a.m. and came back at 8 p.m. or sometimes even 10 p.m. home. But we went to the villages, to the houses, and their health was not important at all. And it's no different in any population. Health is something that we as healthcare team members give a very high priority to. Majority, just our own selves, if we take it, we take health for granted, and health is not important. There are many more other things that are important. But in the community, social things were very important for them. So that should be the entry point. We should go listen to what their needs are and focus on their needs. So the priorities that we build should be what is most important for you, what matters most to you. It may not be, the diabetes control may be awful, but yeah, you keep that in the back burner. You first meet their social need, because that may be what's contributing to the terrible diabetes too. You know, the social problems are so challenging that they are not able to focus on one thing. They don't know what's the right thing to do. They don't have the resource. They don't know where to go. They're going to eat the wrong stuff. They're not going to take their medications, or they don't have the money to buy the medications, or they have side effects of the medications and nobody's asking them about it. So the social is the first point that we really have to enter and start meeting their social needs.
I think that's a very wise position. Dr. Holzenberg?
Yes, congratulations, Dr. Patel. You managed to take patient-centered care to a new level.
Thank you. Thank you. So we did a lot of team building, because it's not enough for one person to have it. Everybody in the team needs to be on the same page. So we spend a lot of time with team building. We have a lot of fun. We have a lot of parties. There's always food when you come. So with this COVID situation, everybody is unhappy that we're not having parties anymore.
Yeah,
that's the time to relate to one another. That's the time to say, hey, you know, we are on the right track.
Interprofessional team building, perfect.
Yeah. And one other thing that I would like to comment, and maybe Dr. Saloom can expand, is that we are going to have our new Institute for Neuroscience building. It's going to be based in Harlingen. And so we are just thinking not only about how the rooms are going to be and selecting furniture and all that, but we want to create a model of care that is really responsive to the community, bringing innovation, but also bringing more. And I think that the CARINO approach will be, very appropriate for, as other people have put in the chat, very appropriate for our Hispanic or Latin community. So I think we have a great challenge, but we have a tremendous opportunity if we have the chance to think together and to work together to implement something.
Yeah, well, yeah.
So when we did sorry, go ahead, Dr. Salom.
No, I just was going to second Dr. Maestre, In fact, what you have mentioned is really, this is the practice, we call patient-centered, but, we would like to call it person-centered, because really you are focusing on the person,
Yeah.
and only, one of the sort of, core principle of person-centered is like to be like relational focus. And you mentioned about the shared decision-making. And so really what this somebody needs, what is the most important things for them, and that's your opening, right? So it could be transportation, could be whatever, very distant from the health, And so I think that would be a wonderful, as a model, conceptually, I think a lot of people have been looking at a little bit different angle to medicine. How do you approach people? And I think there has been many experiences, let's say in the child field, I know some people use this wrap around services, one way to really address the patient's need, and the substance use. If you look at some of the NIDA models, they put the patient in the middle, but you have a whole host of services around them. But I think your approach is very much, it's really a person-centered approach, because you first of all, you have, you highlight the relationship with the patient. You make them part of the solutions. Like, medicine has always been sort of very hierarchical, We go to the doctor because he knows everything and they tell us what to do, right? But really the approach is to listen to the people and make them part of the team, So, that would be a model that absolutely, would love to be able to work with you, because you really have worked a lot about the nitty-gritty and the processes, we can talk a lot about principle, but, when principle hits reality, you want to know how to apply them, right?
Yeah. Well, we can do a needs assessment kind of to find out where we are now, and then see which is the first step we want to take and where we want to go. So our practice, we made it like when we developed the approach, we had a patient and family advisory council at that time, and they basically came and saw this place before we renovated it. They decided on the colors, they decided on the floors, they decided on the lighting, everything. So the patients had a say. And then we had some trouble from our administrator saying, what is this, Dr. Patel, you're using this teal color and blue color and purple. These are not UT colors, and UT is not going to agree to it. I said, hey, these are South Texan colors, very much San Antonio colors that patients have chosen and they want it. So what's our problem in giving them what they want? We've already asked them what they want, and now why do you want me to go back to what UT wants? Let's do what the patients want. So we call it as a person-centered, patient-driven approach.
Okay.
Everything is driven by what the patient needs, but it's very person-centered.
Okay. Yeah. Well, congratulations. So hopefully we can collaborate, on project, and use your expertise. Thank you.
Thank you. Well, and I'm excited because this is what I really want to do as well. I would have loved to come there to present and then go and explore the community a little bit, but maybe there will be a time. Pretty soon.
So we'll find ways, because intention is very powerful. If we keep this in mind and we keep together this fire alive to serve our seniors, you know, we'll find a way. And I have to say, uh, it's really inspiring to see your leadership, the diversity that you bring, how important is to have people with a diverse background looking at the problems, and how can you lead a team, uh, a very diverse team, because I've seen in San Antonio, I've met some members of the team, and also how you battle for your project and for your older adults.
Mhm.
And so you are leading a way for us. And that's that kindness and the cariño approach, it's very powerful. You cannot, you know, they say you cannot cover the sun with your finger, and that's the cariño approach, I feel. I think that we definitely are very interested, we are motivated, and you see the people in the community and in the public service interested. So I think we, you know, we are gonna keep thinking, and we have the promotoras, I think, ready to jump into this. So I'm happy that we have here Dr. Garza also and some other members. So I want to thank Dr. Patel for this wonderful presentation. And it's more than a presentation. I feel like an injection. You know, something has gotten into me, a desire, a stronger desire to change things for better. People say, you know, you can read, this is an amazing approach that will make valid impact to a person. The interest in care is obvious, and thank you for emitting that style of care, and that's such a compassionate, and also it's evidence-based driven, theory driven, and we wish you all the best, the success in your own practice, and we're looking forward to finding more ways to collaborate.
Thank you. Thank you for inviting me to speak and
And
share.